Almost 20% of the U.S. population lives in rural areas, but only 9% of physicians practice in those same rural communities. And with many physicians retiring, the lack of primary care and specialty care can be a significant challenge for rural hospitals. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Petterly, senior writer for the AHA and your host. In this podcast, Elisa Arespacochaga, vice president of the AHA Physician Alliance, talks with Ben Anderson, CEO of Kearny County Hospital, to hear how his small rural hospital took a big chance on an unorthodox approach to recruiting physicians, including offering 4-day work weeks, limited on-call commitment, and time off for international service work. Let's listen in.
Welcome to another in AHA's ongoing series of podcasts where we focus on important issues facing clinician leaders. I'm Elisa Arespacochaga with the American Hospital Association, and today we're talking about physician recruitment. We're hosting a series of podcasts as a companion to the AHA's report on ensuring access in vulnerable communities, which outlines 9 emerging strategies that can help preserve access to healthcare services in vulnerable communities. Today's session will focus on the underlying challenge of workforce and recruiting physicians to rural areas, but as you'll also hear, it's about building and sustaining a community of health. Joining me is Benjamin Anderson, CEO of Kearny County Hospital in Lakin, Kansas. Welcome and thanks for talking with me.
Thank you for having me.
So first, let's start with a little bit about your story, how you came to be a hospital CEO in Kansas and your connection with the International Family Medicine Fellowship.
I started as a CEO in Ashland, Kansas in January of 2009, and at the time the facility was on the brink of closure. It had no doctor for 8 months, no previous CEO for 6 months, and it was in very bad trouble. So it had just a few days of cash on hand and no strategy, and there was a real feeling of discouragement or hopelessness there. And so right away recognized that we had one PA who was working around the clock, being supervised by a doctor who lived 30 miles away, who was coming in 1 day a week to sign off on this PA's charts. And that PA was working 24 hours a day, 5 days a week. And then we were bringing in a myriad of locums providers to cover on the weekends to try to keep an emergency room open, borrowing from our neighbors, from the medical school, from the residencies, wherever we could find coverage. And so we were in a town of 2.5 hours away from the nearest city, far away from any amenities. And I say all that to paint the picture that if there's a place that's difficult to recruit to, that's close to as difficult as it gets. So we recognized pretty early on that we needed a different strategy for medical staffing. And I figured out that the Via Christi Family Medicine Residency and the Via Christi International Family Medicine Fellowship were known internationally. Nationally and internationally for training some of the best full-spectrum family physicians in the United States and perhaps in the world. And they were in Wichita, Kansas. And we knew also that 2 of their faculty at the time were from Clark County, where I was currently living. And so I went and met with them, and I sat down with them. They were brothers. And I sat down and said, "What do we need to do to recruit one of your residents to move here?" And they said, well, frankly, but respectfully, they said, you won't get one of them to move there. You'll get 2 or you'll get none. Good ones don't want to practice by themselves. They're being trained not to practice by themselves. They want to practice with other good ones. And so I'm thinking, I was in a town of 900 people at the time. I was thinking, how do we sustain 2 full-time doctors in a town of 1,000 people? And I mentioned that to him, and he said, figure it out. And I said, okay. So he said, well, once you've made peace with recruiting 2, then you need to also secure for them a physician mentor that can encourage them and help develop them out of residency. That the person doesn't have to be in your community, but needs to be nearby. And you need to secure that for them. You need to give them 4 days per week in the clinic, no more than 1 night per week on ER call, no more than 1 weekend per night per month on ER call. And you need to pay them fairly. Don't take advantage of them. because they would work for less, pay them a national average salary, and then give them 8 to 10 weeks of paid time off to do international mission or service work. And I'm processing all of this simultaneously, thinking, good grief, how do we get this going in a town, in our hospital shape? And he asked me at the end of this conversation, he said, so how serious are you about this model? And I said, I'm serious. I'd put my money where my mouth is. Then he said, then go to Africa with them. And it was this point of reckoning, because my wife was also sitting there. And what he was asking me to do was get a half a dozen shots on my arm and fly over the Atlantic Ocean on South African Airways and build screens for the windows of missionary housing in rural Zimbabwe to keep the black mamba and cobra snakes and the malaria-ridden mosquitoes out of the housing areas where these doctors were staying. And he was saying that if you're really about this, then go learn what motivates them and see if it also motivates you. And so flippantly, I said, sure, we'll go. And my wife just looked at me and said, what just happened here? What did we just sign up for? Wait here. And so 9 months later, after many conversations, we were on an airplane. We went over and did that, and it changed our lives. And I realized that in rural Kansas, we have more in common with rural Zimbabwe than we do with Boston, Massachusetts. And we have the same access to care issues. We have affordable housing problems. We have poverty issues. We have, in some cases, some fatalism that's set in to rural communities. We have health outcomes that are more challenged than our urban or suburban counterparts. So while the problems are similar, so are the solutions. And that's really mission-focused people moving into communities and building relationships with people and serving people radically in very real and practical ways. But putting themselves at risk in doing so. Because in rural communities, it's different than urban. In an urban community, you can serve the underserved from the suburbs. I don't know how well you can do it, but people try to do it often. They'll live in the suburbs and they'll parachute in and serve in inner cities and go home to their suburban communities. Where in rural communities, to serve the underserved, you must become the underserved. You must move to these places where access to healthcare is sparse. And so you experience the same gaps in care as anyone else. It really transcends social class or insurance type.
Wow. Sounds like quite the change for you. So tell us a little bit more about the program you put together in Ashland, and especially some of the lessons you learned in that first year of having those residents come to town.
Well, initially, we tried to recruit, but there were some things that were missing, components in our organization that were missing. And we realized that to recruit mission-focused physicians, especially family physicians, which there are many family physicians who are millennials that are driven by a sense of mission or purpose that's much greater than themselves, who are particularly drawn to rural areas, but they want to know that the organization with which they would be working or through which they would be working also shares the same mission or passion or values. And so we realized that as an organization, we hadn't looked at our mission statement since the early 1980s, since some lawyer drew it up back then. And it was a long paragraph that no one really even knew what it was. And so we had never, to our knowledge, anyone on the board couldn't ever remember where we'd had a vision or vision statement. We didn't have any core values to speak of. And so really our default mission had become to stay open another day. And we realized that really high-performing, mission-focused staff, physician and staff, they're not interested in working for an organization whose mission is to stay open another day. They wanted to be part of something bigger than that. And so we had to spend about a year redefining that mission, vision, values, goals, that strategy for our organization, so that in an elevator, we could communicate that to a person. And very quickly and concisely, we could communicate that to the people whom we were recruiting, because they very clearly knew their own mission, vision, and values and goals. And what they wanted to know was, does yours match mine? And so we actually had to have that in place, and our staff had to know it before we could actually honestly communicate that to physicians. So once we had that in place, we reached out to several training programs and organizations that we knew were connected to these mission-focused doctors. And we said, look, this is what we're after. We rolled out this model that Todd had given us about 4-day work weeks and limited emergency room call, protecting family, those types of things, and the time off for international work. And we very, very quickly began to get interest. And out of that, we recruited 2 physicians, one out of Scott and White Health in Texas. He was in Georgetown. He moved his family with 5 kids up to Ashland. And then we recruited a female physician. We recruited a female physician who was fluent in English and Spanish, and right out of residency who wanted a mentor like the first one that we'd recruited. And both were excellent physicians. They'd served all over the world. And so they moved into that community. And through that, the care was stabilized there. We were able to recruit 2 additional mid-level providers as well, 1 nurse practitioner and a PA. So we ended up with 5 medical providers sharing call 5 ways. Some of them were working part-time. Some of them were working in neighboring communities, or one was even working in a collaborative partnership across state lines, was covering some clinic work in a clinic in Oklahoma and using her Spanish often. So we ended up pulling together a medical staff it really remained in place for several years now. And that hospital, the last weekend, opened a new facility. Ashland Health Center opened a new facility, which should much better meet the needs of its community.
Great. As you mentioned, one of the challenges in a rural community is especially building that network and community, and really getting to know folks. You know, from my own experience in a rural town, if you haven't lived here 20 years, you've just moved here. But how's that impacted your program? And tell us a little bit about what you did to build that sustainable community for your physicians.
So first of all, trust is key. So when I sat down with that first physician, I've never recruited a doctor that I've not gone to their home, their current home, and seen their space toward their current clinic or facilities as the opportunity presents itself. I've never not gone to them. I've always gone to them, and I sat down across a dinner table over a New Year's holiday while our families spent time together. This doctor and I sat down, and I began a discussion around his contract by saying, what can we do as we draft this contract to protect your family and make sure that you see them? And his response to me, a bit surprised, was, well, what can we do to make sure that it's sustainable for the hospital? And both of us simultaneously chuckled and said, well, this is weird. This really wouldn't normally happen in a scenario. Normally, it's the CEO saying, how much work can I get from this doctor for the least amount of money? And the doctor saying, how can I protect my family in spite of this hospital CEO and this hospital wanting to take from me? And it's a real defensive approach. And we just threw that out the window and said, I'm going to choose to believe that you have character and that you care about the sustainability of this operation. And he's saying, I'm choosing to believe that you care about my family and that you don't want me to be burnt out 3 or 4 years from now. And so then the subsequent conversation happened, well, you know, I could do more call than that. And I said, no, I'm not going to allow you to, because I live there and I know what the reality of that is. And for his wife to sit in that family room and hear me say that as the hospital CEO, her mouth dropped. She couldn't believe that her husband was offering to work more and that the CEO of that future employer would refuse to allow that. And so out of that came a deep sense of trust and a personal friendship. I grew to trust him and his family intimately. I would trust him even now with my career. With sensitive information that would affect my career, I would trust him that way, and he grew to trust me the same way. And so when I came to Ashland, it was the same principles applied. That we sat down and standardized physician contracts here, or when I came to Lakin, I'm sorry, the same principles applied, and we sat down and standardized our contracts in a very open and transparent way with hospital legal on the phone, not as a defense mechanism, but rather just, hey, this person knows how to develop contracts well, and that we can both trust this person, and so he's helping us get what we want on paper. But it was never back and forth, and we'll get back to you after legal gets back with us. It was just an open, transparent plan. And right now we have a community of deep, meaningful friendships in our community between our physicians and our hospital administration and our board that goes beyond a working relationship. The most important thing I've done in the last month as a CEO is watch a 2-year-old little girl so one of our physicians and his wife could have a date. That's the most important thing I did. More than anything, any strategic measure, more than or strategic duty or developing contracts or negotiating with insurance payers or town hall meetings or staff meetings, anything else I could have done as an organization, fundraising, all of that stuff is not as important as watching that 2-year-old girl, because they didn't have childcare and they need a date. And those kinds of relationships are very rare, all the more rare in a social media infested environment where virtual community is plentiful and real, authentic human interaction is going the way of the dodo bird, right? It's very, very difficult to find. And so we're finding that these millennial families will live 4 hours away from the nearest Whole Foods store if they have a chance at meaningful human relationships with other people.
That's great. Great to hear how you've built such a community within your hospital. So how have you grown this program to really expand your reach beyond just the walls of the hospital?
So it's evident that the region has noticed that we've recruited these physicians because in the last 4 years, we've added about 8,000 new patients, 6,000 or 8,000 new patients to our medical practice. About just shy of 200 patients per month are establishing care here, and they're coming from up to 120 miles away. And that's a double-edged sword. It's good that they're getting primary care, but it's not good that they're traveling 120 miles to get it. And so we are 25 miles west of Garden City, Kansas, which is a larger city, a regional town, and several thousand of our patients come from there out to our little community to receive care. But there are some other neighboring communities as well where we're getting a lot of primary care from those communities. But we've not stopped with recruiting physicians this way in Ashland or in Lakin. We've begun helping our neighbors recruit physicians as well. We've helped one community about 50 miles away from us recruit 3 physicians to that community. We've helped another community 50 miles in the other direction recruit a physician, another community 50 miles in yet another direction recruit a physician. And in August, we hosted what was called a Focus Weekend, where we hosted 22 family medicine residents and faculty members from 3 very prominent residencies in the United States. We had sponsors fly these physicians or these residents in privately on small airplanes into Southwest Kansas for a group meal that was sponsored by the Kansas Livestock Association and the Kansas Farm Bureau. A Life Team, one of our emergency response vendors, actually flew their private plane down to College Station, Texas, to pick up some of these medical providers, and they came up to recruit in bulk or to be recruited in bulk. So they're looking for places where they can practice both with their friends and near other friends. So most of them would not consider Southwest Kansas alone, but because 20 of them are looking at it, it becomes interesting to them. And so 12 of those 22 have expressed interest in contracts, employment contracts in Southwest Kansas. And so tonight I'm driving, almost immediately following this call, I'm driving to Wichita, Kansas to have dinner with 5 of them and talk about how they could come out here and work as a big group, either in different facilities or in some of the same facilities. And so we are helping our neighbors recruit, which is stabilizing primary care for our region. And the more that we have these mission-focused doctors living in our region, covering each other's mission trips, covering each other's absences, the more attractive this place becomes for even larger groups of physicians. And so that is continuing to happen. And most recently, we are now developing a nonprofit organization that is going to be used as a sending agency or a sending point for physicians to get international training and experience and eventually be placed internationally to do some work overseas. So this will serve as a staffing agency that every time a physician is placed out here through this network, that hospital will donate money to this agency, and then every time a doctor covers another doctor's emergency room or responsibilities while that doctor's overseas, well, that doctor will be paid, but then whatever markup that would normally go to a locums company would actually go into this nonprofit that would actually be overseen by several of these mission-focused physicians, and that money will then go back into supporting residents at these residencies with whom we have partnered, and supporting their international training as well. So it perpetuates. These residencies will be receiving support for their training, and when they're done with their training, they're interested in joining a network that supported them as they were going through training.
Wow, what a great way to pay it forward. So just to wrap up, what advice do you have for other rural hospital CEOs as they work to bring physicians to their communities? What would you tell them if you had just an elevator ride to share your experience?
Well, over this last 9 years doing this, I have gotten to know many of the physicians that rural hospitals would desire in their communities. They would love to employ these physicians. And over, I'm learning that there are more physicians that are wired this way, that want to practice in rural and underserved places, that would come because of poverty and because of health disparities, and not in spite of them. There are more of those physicians wanting to serve in safe places in rural areas than there are safe locations to hire them. And often the barrier is an administrator that doesn't get it, that does not understand what motivates these people, and they deeply desire to trust the hospital CEO that they worked with. One remarkable story in closing to illustrate the motivations of these people and the importance of that trust is when we recruited 6 at one time in the fall of 2015, we ran the risk of running out of money, and we actually did come very close to completely running out of money because we had so much upfront expense and the payments hadn't started coming in. And when that happened, 3 physicians, unaware of the others, 3 physicians came in individually and said, hey, I think you're paying me too much. Here's $50,000 back. We don't need this much money. We don't want to be the source of the hospital running short on money. If things change, let us know. But you can have this money back right now. We don't need it. And in my career, I've never heard of that ever happening. And so that's the result of that kind of trust. And you better believe that when payments stabilized and things got better, I went back to them. They didn't have to ask me. And I said, hey, things got better. We're finally leveling out here. I want to honor your original contract. And they said, thank you. You don't have to, but thanks for that. And that's the kind of relationship that we have. And CEOs are in the driver's seat for developing those kinds of trusting relationships. So just encourage CEOs to think through relationships with physicians differently.
Wow, that's a wonderful story and a great note to end on. Thank you so much for taking the time to join me today, and continued good luck with all of your endeavors.